dorsal inlay, we basically just open the urethra. We open the urethra. We can either deglob the penis or invaginate the penis through the perineal incision. Open the urethra. No urethral mobilization is required, and hence the circumflex artery is preserved. So this is what we do. One of my patients, I deglob the penis, open the urethra, and inside the urethral plate here, we have to dissect the urethra from the underlying tunica albuginea so as to create a wide defect, and then graft the mucosa, and then finally make a urethral tube. Okay. So dorsal onlay, the Barber-Hicks technique has been compared with the dorsal inlay technique, the Assopa technique. The success rate is similar with both, but the Barber-Hicks technique requires a longer time than the Assopa technique. So when do we use a dorsal onlay and when do we use a dorsal inlay, the Assopa technique? So if the urethral plate is more than 10 cm, you can use dorsal inlay only if the urethral plate is more than 10 centimeters, whereas dorsal onlay can be used even for thinner strictures, even if the urethral plate is more than or equal to 6 French. Whereas dorsal inlay would widen the urethral stricture by 1.5 centimeter, meaning you can use only a 1.5 centimeter graft. For dorsal onlay, for a Barber-Hicks technique, you can use a much wider graft, up to 2.5 centimeters. So as I mentioned before, there are people who have done a ventral onlay, even in case of penile urethral strictures, but these are limited papers, limited studies. Even from India, there is a paper where they have done a dorsal onlay as well as a ventral onlay. But then these are small series, and I wouldn't recommend doing a ventral onlay in case of penile urethral strictures. For complex strictures, trying to preserve the urethral plate, they have done a ventral onlay of this oral mucosal graft, and the graft bed would be provided by the mobilized tunica vaginalis flap out here. So these are done in extreme cases, not to be done by everyone, but we have to know that it can be done. So there's a situation where we have to do a two-stage repair using oral mucosal grafts. So these are done in case of obliterative strictures when the urethra is almost gone, less than 6 French in diameter, especially in case of lichen sclerosis or where there is a failed hypospadias repair. One thing is to keep in mind is that the so-called two-stage repair, the first stage is usually a Johansson's first stage, followed by a second stage tubularization. The two-stage repair often becomes a 3-stage or 4-stage repair because the graft often gets infected, it gets necrosed, we have to redo the graft. So whenever possible, you should always try to do a 1-stage repair using oral mucosal grafts. And where possible, while doing a 2-stage repair, do not excise the urethral plate. So always leave the urethral plate behind unless the urethral plate is grossly diseased by lichen sclerosis. Okay. So here is the 2-stage repair for a failed hypospadias repair. This is a picture taken from Kulkarni Institute. So they basically do a Johansson's first stage, just lay open the urethra, allow the urethra to rest for 6 months, and then do a dorsal inlay while after 6 months, and then you close the urethra. So we should talk about penile skin flaps as well. It's another modality of treating penile urethral strictures. So penile skin flaps are basically fasciocutaneous flaps of vascularized island of penile skin. So penile skin is basically supplied by the superficial branch of the external pudendal artery, which arises from the femoral artery here. It gives 2 branches, anterolateral and posterolateral branches. These branches, they arborize in 2 places. They form two plexuses. One in the dartos fascia, just underneath the epidermis. It's the subdermal plexus. The other plexus is the plexus in the tunica dartos. So this second picture explains this phenomena more correctly, more clearly. So this is the fasciocutaneous penile skin flap. Okay, the remaining penile skin is supplied by the subdermal plexus, and this fasciocutaneous skin flap is supplied by the axial penile arteries, which are found in the tunica dartos. In order to preserve these axial penile arteries, while raising this flap, we have to raise the superficial lamella of the pux fascia. You should be able to clearly see these vessels and nerves. Okay, so creation of the flap requires dissection between dartos fascia and tunica dartos, and you should always raise the superficial lamella of the pux fascia. So Penile skin flaps are used for non-obliterative strictures and for non-lichen sclerosis strictures. Lichen sclerosis, presence of lichen sclerosis is a contraindication for using skin flaps. So historically, one of the easiest flaps to create was the Orandi flap. It is basically a ventrally located longitudinal skin flap. It's easy to make. The drawback is that the proximal part of the skin can have hair-bearing areas. So the Orandi flap can be lengthened up to 15 centimeters by developing a so-called Porty flap. This flap was devised by Dr. Porty from Ghana. However, the most versatile flap, which I also sometimes use, is the McCannan's flap. The McCannan's transverse circular penile skin flap. You can harvest it from the inner prepuce, or if the patient is circumscribed, from the distal part of the penile skin. Up to 15 centimeters of the graft can be harvested, and it enjoys a reasonably good success rate. So flaps do tend to fail more often than grafts, which is the reason why grafts are more commonly used than flaps. So there is a 5% failure at one rate and up to 20% failure at 5 years. And tubulars flaps are never to be used, not to be used because the failure rate is quite high, up to 50 to 60% in the long run. So the failure rate of flap is because of the natural attrition of these flaps. The skin basically tends to contract. So the team of Anthony Mundy and Andre, they did a study. So in this series of anastomotic urethroplasty, the failure rate plateaued after 5 years. So it tended to fail up to 5 years. After 5 years, the failure rate basically it remained stable. But in case of substitution urethroplasty using skin grafts or flaps, the failure rate continued to increase for up to 15 years. So wherever possible, use grafts and not flaps. The other problem with using a flap is that flap creates pseudo-diverticulum formation in almost 1/3 of the cases like this. So here I used a flap, and there was a small anastomotic stricture out here, and then it led to a creation of a large pseudo-diverticulum. The other common complication is the urethral-cutaneous fistula. So in order to prevent these complications forming with the use of grafts, the team from Italy and India, they devised a so-called dorsal Orandi, modified Orandi flap. So basically they harvested the Orandi flap, and instead of using it ventrally, they used it as a dorsal only. So they enjoyed a decent success rate. The advantage is that it avoids diverticulum and it avoids fistula formation. The other problem with flaps is that it takes longer operating time, the complications with the skin hematoma, skin necrosis, and issues with penile cosmesis also, penile corrosion. Many patients are not satisfied with the final cosmetic outcome. So again, I would like to say that grafts are to be used. So dorsal only BMC graft has been compared with penile skin flaps in a randomized prospective trial by Dubey et al. From India. They've shown that the success rate is more or less similar, slightly higher with BMC grafts. But penile skin flaps took longer operative time, 224 minutes, and there was higher incidence of penile skin-related complications. In another outcome analysis by Barberly et al., the success rate of grafts far outnumbered the success rate of flaps. So again, I would like to reiterate that grafts is to be used wherever possible in case of penile urethral strictures. So here they have tried to use a flap in combination with grafts, but the primary success rate was very low. So these sort of cases, very complex cases, I would suggest that we do a 2-stage repair than do a single-stage repair. So in summary, what to choose in penile urethral strictures? There are no good randomized controlled trials to compare between grafts and flaps, only retrospective analysis. It depends on the surgeon preference as well, on your surgical training as well. So to summarize, for non-obliterative, non-lichen sclerosis related strictures, we have to use either grafts or flaps. If the stricture is because of lichen sclerosis, you are allowed to use only grafts. If the stricture is obliterative because of lichen sclerosis, failed hypospadias repair or prior flaps, you have to do a two-stage repair with grafts. Tubulars, a tubed flaps or graft is a big no-no. It's not to be used at all. And whenever you are unable to harvest graft, you can use flaps. So this is what Anthony Mundy had to say in one of his articles. In case of penile disorder strictures, it is not always possible to predict the quality of the local tissues of the residual urethral plate. So a thorough intraoperative evaluation is always required, and that is what decides, helps you in making a good decision as to whether to use a graft or a flap. So for the sake of the residents, I have a few scenarios here. The first scenario is a young male patient who had a history of trauma in the past, followed by difficult voiding since childhood. He underwent repeated endoscopic urethral intervention, probably DVIUs. He was seen many times elsewhere, underwent multiple endoscopic DVIUs and UDs, and he was on SPC for 6 months prior to his arrival to our center. So this is what the RGU looks like. So what can you see in the RGU? You can see here's the penoscrotal junction. So the stricture, the narrow part of the urethra extends almost up to the penoscrotal junction. The proximal bulb is almost obliterated here. So what do we do here? As I mentioned in my presentation, my favorite technique is augmented anastomotic urethroplasty. This is a traumatic stricture. We have to excise this stricture, but this part of the stricture is also, this part of the bulbar urethra is also strictured. We did an augmented anastomotic urethroplasty. Just for stricture excision, it was quite long. To do a pass urethroplasty, it was too obliterative. And to do double face also, it was too obliterative. So we did a dorsal stricturotomy on the lower part of the urethra. We assessed the obliteration spongiofibrosis. We resected the obliterated segment, and we did an augmented anastomotic urethroplasty. So this is the excised part. The picture is not clean. It's not very clean. But this is what we did: excise the strictured part, passed a graft, and did a good anastomotic augmented anastomotic urethroplasty. Follow up at 3 months, good urine flow, no good erection, no ventral curvature, no glans insensitivity, and he's a happy man. The second scenario, we have a 68 years male, a high-ranking official from our country. TURP was done 8 months back, and DVIU for this stricture was attempted 5 months elsewhere. So what we can see here, we can see the bulbar bone here. So this is a proximal bulbar urethral stricture. Here is the penoscrotal junction, the middle bulb, and the distal bulb is okay. So, and this is the post-TURP stricture. It looks pretty tight. So here, again, as I mentioned before, you should always put the ideal operation here would be a ventral onlay BMG urethroplasty. Always put a guide wire. Always use methylene blue to stain the urethra. Otherwise, out here in this part, it will be very difficult to locate the urethral margin to suture. Do a stricturotomy ventrally. Cut only the mucosa and the fibrous part of the spons. Use the J-set suture, and do a dorsal inlay as well out here. Okay, so a ventral only urethroplasty with a dorsal inlay for proximal bulbar strictures, secondary to TURP. So here is another scenario: a young patient on whom I had done a progressive perineal urethroplasty for pelvic fracture urethral injury. 3 months after the removal of Foley catheter, he has this bulbar urethral necrosis, so he required a SPC as well. So the bulbar urethra is all fibrosed. So this condition is called bulbar urethral necrosis. So I kept this slide because I wanted to show the McAnan's flap which can be used here. So what we did was we excised the fibrosed urethra. It was a heart surgery. We used harvested the McAnan's flap, but we tubularized this McAnan's flap into a tube. We did a preputial tube flap, and then we anastomosed the tube to the proximal urethra. This patient is doing fine now. So here is one situation where you can still use a McAnan's flap. It can easily reach up to the proximal urethra. A fourth scenario here, this gentleman, a 70 years gentleman who has a history of periurethral who has a history of Foley catheter insertion. He has a mid-bulbar stricture, mid-bulbar involving the distal bulbar urethra as well. It is obliterated stricture, and we can see the compression rhoda muscle. It's compressing the proximal bulb as well. So what do we do here? The stricture part is in the middle bulbar urethra, almost reaching up to the distal bulb. So we did a dorsal onlay plus a ventral inlay. Okay, in this patient, this is the picture showing the ventral inlay as described by Zellman and Stiegel, and we passed a big graft dorsally. An important message while doing a double inlay like this is that the ventral part of the dorsal part, the graft should not be equal in length. It should always be unequals. Otherwise, if you put an equal length graft, it's going to you're going to face an anastomotic stricture at the ends. So here is the fifth scenario: a patient with lichen sclerosis, pan-urethral stricture. What do we see here? So you should always inspect the urethrogram very carefully. You can see filling defects here. This patient had multiple stones out here. So while doing the urethroplasty, we did a single-stage urethroplasty with a double face in this region. The important message is that you can have stones in the proximal part of the dilated urethra. The fifth scenario: a 92 years male, a history of TRP, and he has a stricture here. So what would he do? He's a 92 years gentleman. He's extremely frail. So in this situation, our plan is to just to do a UD, just to do a urethral dilatation, and not a DVIU, because this is a post-TRP stricture. So with this, I end my presentation. I hope